When a runner's heel strikes the pavement, the leg absorbs loads up to 8 times body weight, transferring massive kinetic stress to the Achilles tendon. Because of this repetitive, high-impact stress, Achilles tendinopathy accounts for up to 18% of all injuries in runners. The standard frontline treatment for these injuries is an eccentric loading program, exercises designed to lengthen the tendon under tension. But in many clinical cases, this conservative care hits a recovery plateau, leaving patients stuck in chronic pain. To understand this plateau, we must look closely at tendon anatomy. Clinical literature divides the Achilles into 2 zones: the mid portion, 2 to 6 centimeters above the heel, and the insertion point, where the tendon attaches to the calcaneus bone. These 2 zones do not absorb stress the same way. The mid portion handles tensile stretching, while the insertion point is subjected to complex compressive forces and friction against the bone itself. Standard rehabilitation protocols that treat these 2 biomechanically distinct zones as identical often fail to produce consistent results. When exercises fail, clinicians turn to extracorporeal shockwave therapy. This non-surgical intervention drives pulsed kinetic energy waves deep into damaged tissue to stimulate healing. Despite its widespread use in sports medicine, ESWT is debated. The clinical outcomes observed in practice vary significantly. Some clinics report complete recoveries for their athletes, while others document 0 improvement or even a regression in tendon function. The scientific data on shockwave therapy does not actually contradict itself. It is simply highly specific and frequently misinterpreted by general practice. By deconstructing 2 major medical meta-analyses, we can see that the efficacy of ESWT is dependent on how we stratify the anatomy of the injury. Relying on individual clinic anecdotes leads to unpredictable patient care. True clinical efficacy must be derived from rigorous, segmented statistical data. We start with a 2020 meta-analysis published by Fan and colleagues, which establishes a baseline for how well ESWT works in the aggregate. The researchers pooled data from randomized controlled trials and case control studies, comparing patients who received ESWT against those who only received standard non-surgical care. This forest plot shows visual analog scale scores from the Fan study, where patients rate pain on a continuous line. Looking at the aggregate data, the total summary effect shows a mean difference of -2.14, with a p-value of less than 0.00001. In a clinical setting, a 2.14-point drop on a 10-point pain scale represents a noticeable functional reduction in the patient's daily discomfort. A p-value this small indicates this reduction in pain is a direct result of the shockwave therapy, rather than statistical noise or random chance. When viewing Achilles tendinopathy as a single, generalized condition, this data indicates that ESWT outperforms standard care for pain management. Pain reduction is only one part of the equation. To evaluate actual mechanical recovery, researchers use the VISA-A questionnaire. The VISA-A is a specific index that measures joint stiffness and the ability to perform weight-bearing activities. The combined VISA-A scores also showed a statistically significant functional improvement favoring the ESWT group. However, the study reports an I-squared value of 92%. The I-squared statistic measures the variation across multiple studies caused by underlying data differences rather than random chance. An I-squared of 92%, along with an 88% variance in previous data, is a significant statistical outlier. This level of variance indicates that the trials in this meta-analysis are not measuring a single, unified group of patients. The responses to the therapy are inconsistent from study to study. The positive aggregate score doesn't tell the whole story. High heterogeneity indicates we are actually looking at distinct subpopulations improperly mixed into a single dataset. To resolve this data collision, we look to a 2022 systematic review by Ponchins and colleagues. Their core hypothesis addresses the variance directly. The extreme heterogeneity in previous studies occurred because researchers treated all Achilles tendon pain as a single pathology. They refined the methodology by strictly isolating randomized controlled trials and separating the data based on the exact anatomical presentation, mid-portion tendinopathy on one side and insertional tendinopathy on the other. Segmenting the data this way reduces the statistical noise, allowing us to accurately measure the clinical effectiveness of shockwave therapy when used alongside a standard eccentric loading program. Evidence-based medicine requires matching the intervention to the precise location of the damage, down to the exact centimeter of the tendon. When we isolate the mid-portion patient population, the data clarifies immediately. Adding ESWT to standard care for mid-portion tendinopathy results in a pooled mean difference of positive 9.08 points on the VISA-A functional scale. A 9-point jump on this questionnaire represents a significant functional return, allowing athletes to handle heavier loads with less stiffness. But the results for the insertional subgroup show a different outcome. The efficacy disappears. The data flatlines, showing a standardized mean difference, a metric to unify scores, of negative 0.02. For insertional pathology, shockwave therapy offers zero functional advantage. Specific subgroup analyses suggest it may even have a slightly negative effect compared to using standard care alone. The mixed results observed in daily clinical practice are explained by this division. Shockwave therapy is an effective treatment, but it is frequently applied to the wrong half of the patient population. Combining the findings from these systematic reviews provides a definitive filter for building treatment protocols. For patients diagnosed with mid-portion tendinopathy, shockwave therapy is recommended as a powerful adjunct to traditional eccentric loading. For insertional tendinopathy, the data is clear. The therapy is statistically ineffective and should be excluded from the conservative care pathway. Standardizing this binary protocol reduces wasted clinical time and protects patients from an intervention that will not address their specific injury. Beyond the Achilles tendon, this data highlights a challenge in how we interpret modern medical literature. Accepting the top-line conclusions of a large meta-analysis without investigating the underlying I-squared heterogeneity of the data is a significant oversight. Labeling an injury broadly as Achilles tendinopathy is a diagnostic habit that obscures the proper mechanical treatment. Determining the actual clinical efficacy of any physical intervention requires looking past the pooled data and demanding precise anatomical stratification.